Muted.
The capitation and require you to earn it back by hitting those clinical measures. That's a financial measure. Yeah, if I'm in a contract with a payer and the benchmark is set by a percentage of the medical loss ratio, does that constitute quality metric? My answer was no. It could be. It could be a measure of access to services, but it's not a quality measure. And because the categories specifically require a connection to quality, it wouldn't qualify. That 3N and 4N are either capitated payments not related to quality or risk-based payments not linked to quality. The N means no. It's a weird system how this is developed. If you're in 3N or 4N, it doesn't count as value-based payments. There has to be a connection to quality. I know that you could define quality to include access to care, but I don't think that's what their intent is here. They mean about the. You could argue it, but I'm not sure it'd be successful. Other questions about the categories 1 through 4? So many states have pushed forward with value-based payment, doing different things in different ways. Some states mandating value-based payment, adopting certain models, others by doing a model, testing things out. Some require a specific percentage of provider payment through value-based payment arrangements, multi-payer arrangements. States sometimes adjust premiums. What did Washington State do? All of that. But before we get there, where Washington State draws the line is somewhat different than, for example, New York. So New York defined value-based payment in category 3A, meaning that the MCOs didn't get credit for a value-based payment unless they had a contract with a provider where there was shared savings. That's really high. That's why in New York State there's been so much delivery system and transformation stuff going on, because the MCOs need providers to take at least upside gain risk against the benchmark. It doesn't mean anything to them if you just have a provider that's getting a pay for performance program. It does not qualify in New York State as value-based payment. So New York State drew the line very high and very aggressively to define value-based payment quite high. Washington State is more typical, drawing it at 2C. California, in some cases, have 3 and 4, so a higher level of value-based payment. So in many respects, Washington State has charged forward and has value-based payment, but they define value-based payment relatively in an easy way, that should be an easy way for the payers to make those numbers. Just don't have more than a minute. Okay. So what did Washington State do under its program? Washington State did a little bit of everything. First, they set, as I mentioned, a very heavy lift, a good aggressive goal. 90% of state finance payments to providers will be in APM categories 2C to 4B by 2021. And a lot is riding on this, right? Because the state has to do this. If they fail to make that number, the state loses money. The DSRIP program is conditioned where the state actually won't earn all the money from the Fed if they fail to meet their benchmark. So the state has a very strong interest to ensure that payers meet their targets. Then there's basically 4 buckets. There's the MCOs are being managed because the MCOs have a premium withhold, either 1 or 2% here in Washington State. So the MCOs are losing a percentage of money from their premium dollars, and the MCOs have to do well to earn it back. And even if it's a small withhold of 1 or 2%, remember, that's millions of dollars. Because there's millions of dollars being pumped through the managed care companies. I think HCA is accountable for something on the order of $10 billion of healthcare spending, because it's not just Medicaid managed care, but they're responsible for all the public employees and I think even some of the school employees as well, their health insurance. So they have basically huge leverage with the payers in telling the payers what they want. So even if you think that, even I don't know how large the Medicaid program here is, $5 billion, distribute that over 5 MCOs, each MCO in a region is getting in the state is getting $1 billion, and you withhold a percentage or two, talking about hundreds of millions of dollars on the line from the incentive program. So MCOs, they don't want to leave $150 million, and not earn it. They want to receive it. So what the state did is they have these different ways, different targets that the MCOs could recoup their withhold. The first is a provider incentive target. So what percentage of the payments in value-based payment arrangements, 2C or higher, were directly conditioned on meeting quality and financial metrics? What does that mean? Let's say I'm a provider and I get paid fee for service. Is that going to count for anything? No, I don't get anything more. What if I'm a provider and I get paid fee for service and pay for performance? And pay for performance is conditioned on hitting clinical measures. Okay, now I'm in 2C, right? So the plan will get overall credit from having a provider in that arrangement. But do they get full credit under the provider incentives target? All the dollars that they're paying to that particular provider? Is that how that metric is calculated? No. Only the dollars that are at play, the additional dollars I might earn, that are conditioned on meeting quality and financial metrics. So I think it's like 1 or 2%. It's not very high, but basically the MCO can only count the dollars, the pay for performance dollars, not the underlying fee for service dollars for this metric, because the state is only interested on the incentives that are being paid to providers. They're trying to motivate MCOs to have incentives. The incentives could also be the shared savings and shared losses components under category 3. The additional money a provider might earn by achieving outcomes on quality or financial metrics. VBP arrangement target is just a percentage of provider payments that are in the form of VBP arrangements. So that's the broader metric. So they look at all the MCO's payments to providers and they count just those that are in value-based payment arrangements, which could include the base payments if you're in fee for service, if there's pay for performance, as well as all the capitated arrangements, because that would count as long as there's a link to quality. So that's a different metric. That's called VBP arrangements targets. We're trying to encourage MCOs to enter these arrangements with providers. And that's the ones where I feel like it should not be a heavy lift in this region to have the bulk of providers under VBP. Because 2C could be for all those that are in fee for service, as long as there's pay for performance. 3A and 3B, of course, are shared risk and shared savings. 4A and 4B are for capitation arrangements with providers. 4A is for maybe primary care. 4A can also be for behavioral health services, as long as there's a link to quality. So there's ways that it can happen, and being rural shouldn't make a difference, shouldn't factor in any of it. Do you have to have a certain number of lives to be in a capitated arrangement? Yes. So that could be a problem with a small provider. Do you have to have a certain number of lives to be in a 2C arrangement for pay for performance? No. Why? You don't have to spread the risk around across a large population in the same way that you would under category 3 or 4. So the size should not matter for a 2C arrangement. It would only matter in categories 3 and 4. Yeah, question. So, Adam, how does HCA encourage those arrangements? Oh, the ACHs. Okay. Well, I think that you would, I'm an outsider here, but what I would think is that you would want to try to frame the situation so the MCOs want to contract with your members under systems that meet their value-based payment requirements, right? Because if I'm a payer and I want to earn back the premium incentives, then I want to make sure that my providers are up to the task of doing it, right? And what I didn't tell you yet was that most of the money premium is earned back not through VBP, but through clinical quality improvement scores. 75% of the withhold is earned back by the plans achieving the target on quality. So I would think that would set up an opportunity where the ACH would want to be measuring the quality and helping the providers in the community achieve those quality targets so that the MCOs would be interested in compensating them for those activities, right? Because that's where the biggest return on their plan's investment is in support of efforts. So if there's a gap in some of those quality measures, then how can the MCO be a helpful partner in funding initiatives that support the quality of care outcomes that they are being measured on?
Well, for me, the answer to that question is the ACH, since forever, since the beginning, has educated the providers from our ACH about value payment and performance measures, and with contracts of certain milestones, all those milestones are clinically based. So the ACH has already set us up. I don't mean that in a bad way. They've already helped us prepare for value-based payment if we pay attention.
I want to go back to a comment you said just about size. I know that when the rubber hits the road, when they're talking about caseload or panel size, with our contract, until we had, like, with each of our MCOs, a minimum of staff members, that from an administrative standpoint, it's really difficult to make it with either our file or the MCO's file to set up those people to be able to have the staff resources to provide that. So, I mean, realistically, if you have less than 1,000 members, should you be working on this with a particular MCO?
So the question is if I'm a smaller provider, should I really be trying to get a pay-for-performance contract? So let me back up. So if you hear from a plan, you're too small, or if you hear from a plan that you don't have enough lives. The question is, why are you too small? What is the cost that there is concern? For capitation, there's a financial cost in you taking downside risk if you don't have enough lives, right? Because you can't spread the risk over spread the risk over a large volume of patients. That's a discrete financial kind of risk in the arrangement, inherent in the arrangement. To me, that's a very different kind of risk than being a smaller provider under pay for performance and incurring staff time, like you're saying, to make it worthwhile. Yeah, you're right. There could be, for the number of patients that you serve, if you're small, it may not be worthwhile from the MCO's perspective to dedicate that much staff time if you serve a small population. But on the other hand, if it would qualify them to hit the provider incentives target or VBP arrangement, maybe they're going to ignore the staff time that's required and still want to do it. But it's not inherent in the financial relationship that you're too small to take the risk. You've just decided, or maybe they've decided, you're too small to make it worth your effort. That's how I would distinguish it. But I think most of those thresholds are arbitrary, like 1,000. Why 1,000 patients? Why was that chosen as the threshold to make it worthwhile? I don't think there's anything magical about that number. Other questions on that? I'll keep going. So quality improvement score is the bulk of how an MCO can earn back their results from the plans. And I think improving on quality improvement is hard. And that's why I think ACH is actually could serve a vital role in helping the system, the region, hit those numbers. Because they're more, from what I understand, the ACH is far more focused on delivery system transformation activities and the supports needed to improve quality. Challenge incentives are basically, what about those withhold dollars that are not earned back by the MCOs? Where do they go? They go into the challenge. MCOs that do have much higher performance are eligible to earn those additional dollars as an incentive. And then there's the district funds that fund ACHs. There's just money that funds the MCOs for reporting certain things, and that's all based on district money that's made available basically by the feds to them, but that requires the state to achieve outcomes and move to a value-based payment arrangement. They hit that 90% of state finance payments made under APM between 2C and 4B by 2021. So that's the hope and desire of Washington State. Now, will it work? It's hard to know. I mean, New York State, who I said is further along, New York State is having huge budget shortfalls this year, right now, because Medicaid spending is above their expectations, beyond where they planned. So the system may be transforming, but the state has not found lower cost of care even through that systems transformation. You know, it's an open question whether moving to value-based payment is going to cost more money for the state or, really bend the cost curve. New York had hoped that it truly would result in lower hospital admissions and ER visits, and the cost would come down. But there's no guarantee that it will be. So you can have a state that goes through transformation and it does not fail on lowering total cost of care. So where does that leave you? Where do you start? I do think there's an argument to be made by all behavioral health providers that the MCO should want to include behavioral health in value-based arrangements because it has the potential for them to earn money, their capitation rates back, their withhold back by achieving clinical score measures and by having incentive arrangements with those providers, so managing the total cost of care. And I would promote specific arrangements. You know, if you hear back from an MCO, you don't have enough lives for you to take downside risk, and say, okay, that's fine. Why don't we do a 2C arrangement? We know that counts for you. 2C, we're willing to do that. That's performance. Why can't we do that? That should not require a certain number of lives, just a commitment to engage in that and dedicate the staff time for doing so. What if you're in a value-based payment contract? Are there specific things that you need? Yes, absolutely. I've seen these contracts fail because the contracts were not favorable to providers to do well under them. So we had an early question this morning about how do I get claims data? How do I get data that I need from the MCO? And one way is really through a value-based payment arrangement contract, just sort of diving in and being entitled to data. The best time to negotiate for data is when it's clear to the plan that you need the data in order to do well under the value-based payment arrangement or make it operational. So a foundation principle that you should bear in mind is if I'm in a value-based payment arrangement, regardless of the category, what information do I need from the plan in order to be successful? Let's say it's pay for performance. It's just based on hitting clinical measures. 2C, the easy one, so to speak. Okay, what do I need from the plan? Well, maybe I need the roster of the patients that are being attributed to me upon which my performance is based. Maybe I need the plan to send me quarterly or monthly data on how I'm scoring on these clinical measures so that I can monitor and manage those measures and do better on them. Maybe what measures am I being measured on? You know, you want to make sure that you have capacity to control the outcomes on those measures. If it's shared savings or shared risk, I better get a claims fee, you know, monthly or every quarter. Plug into my platform so I can identify those patients who are ending up in the hospital that I think I can avoid them ending up in the hospital if I do well. And if it's capitation, even better. One issue I've had here in Washington State, some of the providers that got paid a capitated arrangement were subject to huge clawback by the plan. The plan would pay, let's say, for behavioral health in a particular county or zip codes within that county. And then if a patient that was assigned to that provider went elsewhere, basically the plan would charge the provider for it. They would deduct from their capitated rate the amount that they paid that other provider where that patient went. So being very clear at the outset who I'm responsible for and where my patients that I'm assigned responsibility for are getting their care is important to me managing the dollars that I'm receiving. You have to have a discussion internally basically figure out what data do I need. Specify, the contract should specify the data that you're entitled to, the timeliness, the frequency in which the MCO updates that data, and then ask yourself, what should my remedy be essentially if the plan fails on its obligations? So I helped a network in New York State. They set up a value-based payment arrangement. There was a shared savings arrangement, category 3A, and then the MCO, they kind of balked on their obligations to provide data. They provided the network data every quarter, but each quarter when they provided data, they revised the prior quarter's data. So in the first half of the year, it looked like the network was going to earn shared savings. But in the second half of the year, the MCO revised all the prior reports, and now they were having a loss. And that wouldn't have been so much a problem if it was simply a contract for shared savings, but the network had agreed to move to downside risk in the second year. Well, they couldn't do that with a partner who was changing the reports after the fact because they couldn't manage that risk successfully. And the plan wasn't just changing the reports because of a claims lag for data coming in. They actually had computational errors. They miscalculated the amounts that they were attributing to the population that was attributed. So the network said, we want either out of this contract entirely or we want to delay our own contractual obligation to move to downside risk. Because clearly the plan is not going to be a reliable partner for engaging in that. And they had to renegotiate the contract to bump that out. So that's one remedy. But let's say you put together one of these contracts, you're expecting that data, and in order to do well, you hired new people, new staff, or you bought an expensive platform to manage those costs. And then the MCO fails to live up to their obligation. Should there be some other penalty on the MCO? You made an investment on the premise that you were going to get data from the MCO that would allow you to do well. Now the MCO breached their obligation. They'd be basically required to reimburse you for the investment you made. These are all the conversations you need to think about and have, sort of internally and then with the MCO, to make sure that you have limited your financial exposure if the MCO doesn't do its part. This probably turns your typical arrangement with an MCO on its head, right? Most of you are expected, from experience, expect one thing from the MCOs: money, right? They pay you. Because the traditional contract between you and an MCO is, I'll provide the service, you pay me for it. Now this turns it on its head, and now you don't need just money from the MCO, you need information and data. And MCOs are pretty limited on what they share and when. Now you need that data. That data is essential for you doing your work under the agreement. Some MCOs say, I have a question on this before I move to the next point.
So I'm a behavioral health agency. Can I say at the end of 12 months or at the beginning of the following year, I'd like to receive a report summarizing all the claims that I submitted by ICD, by CPT, by other modalities? Is that a reasonable expectation?
I would be, yes. The question is, can I require them to report specific data to me? And I would say yes, and you should have that specificity in the contract so that there's no ambiguity. Most of the way the MCOs will write this contract is that they just say, we'll provide you reports. That explain how we attributed patients and what costs we charged against them, but they're not that specific. I think that leaves you at a huge disadvantage. Like this network that I was working for, they were concerned that the MCO was charging costs to that basically their benchmark that shouldn't have been. That they were including, they set up a benchmark and they were counting costs that should have been outside and not been applied to the benchmark because they were not relevant to the benchmark or they were not part of the deal. The only way you can verify what costs are being charged to the benchmark is to receive the data and actually look at it to see exactly what costs are being applied and charged towards the benchmark. I would encourage you to have that specific detail in the contract so that you're not exposed. The plans are pretty savvy. They know how to set the benchmark and they know what can be charged against it. And the only solution you have to ensure that they did things right is to actually request the data and the reports to verify what they did. So yes. Some plans will say, no, we can't share that information with you. It's a violation of HIPAA. So let me give you my example that I gave earlier. The Washington State provider, a behavioral health provider, they were attributed patients for their county within their zip code. And then they had the MCO taking money back, pulling money out of it because some patients that were assigned to them were going to other providers. And then the provider said, well, I want to get claims information about what you're paying that other provider because I'm losing money on all those patients that are leaking out of my system and going to that other provider. And you may have a plan say, oh, I can't share that. That's a HIPAA violation. Really? That's not true. So HIPAA is often used by a plan as a weapon, or a sword, maybe I should say, to prevent them from sharing data which they can. So HIPAA does not prohibit a plan to share claims data. I'm not talking about Part 2 data right now, but just generally, it does not shield them or prevent them from sharing data with a provider. Why? Because they're a covered entity just like you are under HIPAA. Covered entities, as you know well, can share information related to treatment with another covered entity, with a provider, without patient consent. That's why you don't need a business agreement, associate agreement with a plan to share that data. And the definition of treatment is very broad. It includes management and coordination of care. That means that if doesn't matter if I'm a behavioral health provider or not, I'm a provider, and I am responsible for managing and coordinating all the patients that are attributed to me, there's no reason, HIPAA does not block the plan from sharing claims information with me about where my patients that are being attributed to me, even if I'm not their direct service provider, but it does not block the plan from sharing claims information about where those patients are going, so long as it's for the purpose of treatment, which is defined as coordination and management. So I'm using that information to manage my patient load, the attributed patients. HIPAA does not block providers covered entities sharing that information. And if you doubt this, then think about the next time a hospital shares information, maybe with you or another provider, when a patient is being discharged. They can do that, right? Because they're both covered entities, and the sharing of information by the hospital is for the purposes of treatment. Making sure that patient, that other provider has the capacity to take on that patient. So they share information about that patient, even though that patient never stepped foot in that capacity, in that provider. They're sharing the information for treatment purposes. Question?
Produces panel rosters that assign patients to particular primary care providers, primary care providers who are expected to take coordination of care. Okay. So let's say I'm FQHC ABC, and I have my panel roster, and I want to find out where all my patients are going to receive care, whether it's with me, another FQ, a hospital, somewhere else. Can I request that information from the MCO?
Yes, you can request it, and HIPAA does not bar or block the MCO from sharing that information with you, the primary care provider, so long as the information is furthering the purposes of treatment, meaning coordination and management for the patients that are being attributed to you.
A follow-up question, Ed. So actually in our contract for our first cohort, year 2, we're requiring our providers to check their monthly rosters that they get from the MCOs. And that, one, to protect them so that if the patient is attributed to them, but they're getting services somewhere else, they can figure that out. But also if that patient is coming to them that it's not attributed to them and they're not getting the payment, then they know that. So do you know if the MCO, as part of their healthcare authority contract, if they are required to provide this monthly roster attribution report to the provider?
That's the $64 million. Are the MCOs required to provide information to the providers? I haven't seen anything in the model contract that requires the MCOs to share that information.
So then the providers have to ask for that report and
negotiate for the disclosure if they have a contract with the MCO.
Is that the only way that they can get that is to negotiate that? Otherwise, they just can't simply ask and get it?
They can ask, but the plan has no obligation to share information unless it's under their contract that they have with the MCO.
So if we wanted to push that, because the healthcare authority was very interested in talking about that with the Greater Columbia GCACH, we should be pushing the healthcare authority to include that in all MCO provider contracts.
Exactly. So New York State just did an amendment to their model contract to require the MCOs to share data with providers that are under value-based payment arrangements.
Okay, great.
I would encourage advocacy around that.
And one of the metrics that they all have in Washington State is a metric of what percentage of a provider's panel is seen at least once a year. That is one of the state metrics. So most of them provide them electronically, either in their portals or they send them directly. I don't think that's an issue in our state.
I think it'd be interesting knowing if there's an issue between behavioral health and primary care providers. Okay.
Yeah, behavioral health doesn't get up.
No, 42. Yeah. So that's the HIPAA side. So there shouldn't be a problem with the plan sharing data with any provider that needs the information for coordination and management purposes by the plan. Part 2, of course, does create issues under for disclosures related to addiction services. That's a more restrictive obligation. But I've yet to have a plan say, I can't share data with you because of Part 2. I find that the plans are woefully uninformed about Part 2. And so when So I don't usually see that as a reason why they have to withhold data and not share it with a provider. I mean, it'll be novel, maybe you'll hear that, but generally Part 2 is definitely more restrictive, but I have not heard that as an excuse for the sharing of data. Performance measures. So let's say you are fortunate enough to have a value-based payment arrangement with a plan that has performance measures related to it. Certainly that's good, but here's some practice pointers to be thinking about. You want to know who you're being measured to. So what patients are being attributed to you under the plan's attribution model. Now they're measuring your performance on clinical measures. Because like was mentioned before, you might be taking care of people that come in and out, but they may not all be attributed to you for the purposes of calculating your performance under clinical measures. So clarity around the population of patients that you're going to be measured on. In addition, what measures? Are they all going to be focused around behavioral health measures? Or if you're a behavioral health provider, would it also include some primary care measures? It's up to you to decide whether you're equipped to do so, but the plans may be very interested in you helping them improve their performance around primary care, even though you're not directly providing, in some cases, quality of primary care. So it depends on you, but it's up to you to negotiate what measures you're going to be responsible for. The second thing, you don't want the plans to change the game midstream. So you don't want them mid-year to decide to upend the performance measures, change the measures, or change the methodology that they use to calculate your scores. These are the 2019 quality measures that have been included by HCA in the Apple Health contract. This is where they can earn 75% of their withhold dollars back on this subset of measures. You may know that there's a longer measurement that the plans have to report data. Correct. The ones that the plans have dollars at play, where they can recapture their premium dollars that have been withheld, that's a smaller subset of measures, just these measures. And you can see a few of them have to do with behavioral health, but they're largely primary care. So if I was a provider and I had a pay-for-performance program or a student capitation program where there was a withhold based on quality measures, I would expect the plan to include these or a subset of these measures as the clinical measures. And I'd want to know from the plan, how are we doing right now on the patients that are being attributed to me against these measures? What's the target? And do I have the capacity to, influence outcomes and improve performance on those measures? Maybe I'm already hitting some measures. Great. I don't have to do anything different there. I can do an intervention, design an intervention just to address those where the scores are low. What about if a plan offers a pay-for-performance rewards or an upside-only arrangement? I always encourage providers to try to seek those arrangements because there's no downside. Other than the staff costs that have already been discussed, there's really no downside to a provider from doing pay-for-performance or upside-only shared savings arrangements. In fact, I've played this game in contracting. A plan will offer a contract, and I write back in it pay-for-performance or shared savings, and I see what sticks. Sometimes the plan will strike out the shared savings. They'll leave the pay-for-performance. Well, that's more dollars on the table than originally contemplated by the contract. Now the provider gets fee-for-service or whatever they've negotiated for base reimbursement and are now eligible for a pay-for-performance program. So don't hesitate to promote or offer up the idea of pay-for-performance in your contracts and plans. If they say no, you're not ready or we're not ready to roll this out yet, think about having a contractual agreement where in year 2 under the contract, the plan will extend a pay-for-performance program to you so that you are contractually entitled to it in the subsequent year. What about downside risk, pay-for-performance penalties, or downside risk arrangements? This is where you want to definitely use the pause button and think quite carefully about whether you are well equipped to manage downside financial risk. Some of you may already have been basically managing that risk. If you are getting paid as a behavioral health provider by a BHO, a fixed amount, you are already managing downside risk because you got a fixed amount regardless really of how many services you're providing. That funded your capacity at a certain level, and you could get overrun with patients or provide more services subject to that and a fixed amount of money. Think about some types of fee ceilings that might apply in the event that you had some downside risk. Some providers that are savvy, they'll enter a downside risk arrangement, but they'll have a fixed dollar amount or fixed figure to limit maximum financial exposure. Because maybe the provider's board of directors says, what's the maximum amount, we could get harmed by under this contract? And there's some limitation in the contract that limits total financial exposure. So that's a smart financial move. Other ways you can do this, you can actually limit percentages to a fixed amount of the benchmark. You can also have contracts where I've inserted language that if there is a loss in 1 year, it can be paid back by subsequent gains in future years. So you may know going into a contract, you're going to have some steep learning curve. Year 1, not expecting anything. But maybe in year 2 or 3, we'll be eligible. So we write in a clause that says losses in year 1 can be paid back by gains in year 2, 2 and 3. So you don't have to cut a check out at the end of year 1. You can hold that and pay it back in future years. And I've seen some MCOs actually say if the plan provider never earns money, never gets any gain, the plan will just write it off. Say, never mind, let the debt and it'll be written off. Then there's really no downside financial risk to the particular provider at the conclusion of the contract. One of the hardest things to figure out is the plan deciding which of their enrollees you're going to be responsible for. And this is sort of an area where there's lots of variation across the country. You have some places where MCOs simply attribute like primary care. They're wed to it and they don't do anything about it. In other places like Washington State, they've actually changed the attribution process to work, to basically retain some historic BHO relationships. So many of the fixed attribution methodologies are based on a geographic area. I'm one provider, behavioral health provider. I'm assigned or attributed all the rural plans and roles for everybody in my county. That's an attribution methodology. Now the plan is measuring performance on all those people that are attributed to me. Plans can do it in other ways too. They can attribute specific behavioral health diagnosis to a particular type of provider. That's a possibility. Receipts from services by a behavioral health agency. I'm responsible for everybody who comes to my door. That's my population. Receipt of health home services. Everybody that's assigned to me as a health home, I'm attributed to all those patients. And the plans are the ones that actually get to decide the attribution methodology, usually in negotiations with the provider. The state's not saying it. Typically, the plan is coming up with the methodology. And they'll, of course, choose something that works well for them, but you should have input into that process to make sure that it works. How can it not work? The practice point is that prospective attribution is sometimes takes the providers by surprise. Prospective attribution is a system where the provider knows on day 1 of the performance year who they're responsible for, who they're attributed. How would a provider know that? Because a plan looks back in their claims data and attributes patients based on where patients went in prior years. It sounds good from the provider perspective because now you're not waiting to the end of the year to figure out who's been attributed to you. The downside is sometimes patients move around. So you might be attributed patients who came to you last year, but is actually going someplace else for their services this year. So you have to be aware, or you have patients that receive services from you this year, but they're attributed somewhere else because they used to go to places last year. And that's where the provider rosters become increasingly important for providers to actually know, who am I responsible for? Because not everybody coming through your door, you may actually be attributed to for reasons based on prospective attribution. So there's based on a prospective attribution methodology. So my recommendation is if you're in negotiations with a payer that involves prospective attribution, or even after the contract is signed, ask them for the roster so you can see who you're responsible for. Or write in a contractual requirement that they have to provide you monthly rosters so that you can manage exactly who's being attributed to you upon which your performance is based. Ask the MCO to provide this list in advance of the start of any performance period. Every January 1st, changes, you get new enrollees assigned because it's based on prospective attribution. Make sure you get a list in advance before that January 1st date based on the plan's claims data, claims report, And certainly the plan can update that after January 1st, but get a running start. Because most providers tell me, I don't know who I'm responsible for, I can't manage them. So monthly patient rosters, quarterly patient rosters, and then what do you do if we disagree? Let's say you look at the roster list and say, I think there's some errors here. You want a process to resolve any errors made by the plan, where they have assigned people that shouldn't be attributed to you, or they are not attributing patients to you, not putting on the roster sheet people you think should be attributed to you. So what's the mechanism to respond to any kind of disconnect, to put it nicely, between the plan's rosters and your actual data report? What about the contract terms for value-based payment arrangements? It depends. How long do you want to be in bed with the MCO under the arrangement? The contract term defines how long you've agreed to be in the contract with the entity. And contract terms for VBP may be different than your underlying agreement. You may have a base agreement with a plan that is a one-year term and then continually just renews. Your VBP arrangement could be a 3-year term, fixed. Because the plan doesn't want you jumping out of the agreement after they've invested in you and given you data for the first 2 years. You may have a longer VBP contract term, which is not a bad thing. It means that they're not going to kick you out either. The contract term guarantees you, in a way, because they are obligated to continue your participation in it for whatever that contract term is. And certainly if you have one of those clever provisions where you can pay for losses in subsequent years, you may want a fixed term of 3 years or 5 years, whatever makes sense, so that there's a longer time horizon for you to generate the upside, the gain. What if you do terminate early? What happens to the gains you might have hit, but that haven't been paid to you? Let's say you decide on, what's today, December 11th, that you're going to terminate the contract as of January 1st. The contract ends. But then there's a claims run done by the plan, and they realize in July of next year that under the contract, you would have gotten some shared savings or some kind of bonus. Should you give up that? No, because that was for the performance year that ended at the end of this year. So you should make sure the clause is clear that just because you terminate the contract or the contract is terminated, you have not forfeited your gains from completed performance years. So the way the plans can recoup money that go to your pocket. Here's. Sure. How is the process for resolving attribution issues done well? When we get to part 2 this afternoon, you'll see a clause that has to do with disputes. So the way that I think the ideal disputes provision should be written is it should allow the parties to meet in good faith to resolve any disputes, like the easy way. You know, maybe that requires some language that says that the principals of each parties or the CEOs resolve any disputes and try to work it out themselves, and then you kind of go up from there. But I would be hopeful that any kind of attribution disputes, you know, you're not going to court about those decisions, that there's a process sort of at the level of the entities coming together to resolve. What if you want to get out? Let's say you're in a downside risk arrangement and you're getting killed. You are losing money left and right. Or you had a capitated methodology and for whatever reason, didn't do it right. You know, whatever the amount set is not sufficient and you're losing money, you're in the red, and you want to get out. Well, first thing, you usually have 2 flavors of termination. One is for cause and one is without cause. So you might not be able to terminate for cause because usually your how well you're doing financially is not a reason that allows to terminate the contract. So maybe you have a termination without cause provision, which is sort of a backdoor to get out of a contract term early, where you can just provide the other side notice and that will get you out of the arrangement. You don't have cause because it's termination without cause. Essentially, whatever that notice period is to notify them, that becomes the length of the contract. Because either party can just provide that required notice and can end it. So I've had situations where parties can't decide on the length of the contract term, but I can be kind of sneaky and insert a termination without cause provision, which gives another way to exit the contract if you have concerns about how well you'll do and you'll want a way to get out. Is it double-sided? Yes, in the sense that it can hurt you too. plan can exercise their right to terminate without cause and end the contract early. It doesn't just protect you and give you the ability to do so. So there's some downside there, but it's a way to get out of the contract early if you want to. I had an IPA, they wanted to disconnect, to put it nicely, from one of their vendors that they had hired to manage their risk, and they had a termination without cause provision. They were allowed to part ways with their vendor before the end of the contract term under a termination without cause right. What about amendments? I see an awful lot of amendments for value-based payments. Plans changing their methodology, changing how they calculate things, fixing errors they missed the first time around. Amendments are fine so long as they're mutual, right? So long as you can weigh in and decide whether they should apply, go forward or not. I see sometimes very broadly written language where plans have the unilateral right to amend their contracts or change the exhibit, change the methodology for value-based payments. If you don't want that, you want that to stay fixed or be changed by mutual agreement so that it's not one-sided. Well, can you believe that? That was all step one. That was all the preparation phase. Everything else is easy and short. It's kind of a joke. But seriously, the preparation phase is clearly the most important because you have to go into these arrangements with your eyes open and understand the dynamics between you and the plan. Why would the plan want to do this? What do they get at? And what can I use to get, what arguments can I make to the plan to make sure that it protects me in the process? One of the things I always heard when the Affordable Care Act was passed and all these new payment models were being discussed, the goal was to put providers back sort of in the driver's seat for how they get paid from a plan. The downside is it's pretty scary, right, to be in that driver's seat. To move from a situation where the plans are telling you how they pay you and how much they pay you to you telling the plans how you want to be paid and how they should pay you, that's a big leap. And that's why through these trainings and other ways that you can understand and learn and work collaboratively to figure out what is a way that is supportive of what we do. How would I want to be paid in the ideal system? Most providers haven't gone through that process and really asked themselves, what would the best way to be paid by a plan be that supports what I'm doing and the outcomes that I want and the plan wants? It's hard. It's not easy to do. Any questions on part one on the preparation phase before I dive into part two? Yeah, Wanda.
And I'm not in Washington State, but some other states talk about the whole idea of retrospective attribution. How does that work?
So the question is, how does retrospective attribution work? So I mentioned first prospective, where you know on day one of the performance year, and it's done by claims data looking backwards. Retrospective attribution waits to the end of the performance period, down over here, and then looks backward just on the immediate performance period that precedes it, and then makes the attribution decision. There was a lot of policy debates, if you're policy wonks like me, about which should providers do. Should they do prospective attribution or retrospective attribution? And there's actually fair arguments on each side. Providers that didn't like retrospective attribution didn't like it because they had to wait to the end of the year to figure out finally here who they're responsible for. And they wanted to know on day one who they were responsible for. So they are in the camp that they liked prospective attribution. Those that didn't like it say, I don't like the perspective. I want to be responsible for just the patients that come through my organization, and I want to wait to basically the end of the year. And I want the payer to look backwards. I prefer retrospective attribution. The Medicare Shared Savings Program actually does a little bit of both. And one of the tiers, it permits retrospective attribution, but they do sort of an interim prospective attribution. So at the start of the performance year, the CMS, the Centers for Medicare and Medicaid Services, looks back on claims data to do a preliminary interim attribution that the ACOs can use. But then the final attribution is done at the end of the performance year, just looking back to where patients went and whether those Medicare beneficiaries actually went to providers that are participating in that ACO. So it's retrospective. The ACO could elect whether they wanted prospective or retrospective.
From a provider standpoint, is there satisfaction? Is there which one seems to work better?
No, I haven't heard of it.
So we should be fighting for it.
Between one or the other? No, I think you should just decide which you prefer. I think the dominant model is perspective, and have that system work the right way. Just know its limitations, right? Because it's going to be decided in advance who you're accountable for.
Well, we know the limitations of perspective, but I'm hearing a lot of senators really working to try to look at retrospective because we know the limitations of perspective.
So I think you have to kind of take a fair and balanced approach. Sure, look at retrospective, but be aware of the limitations of that too. Right. Well, let's go forward here. Let's talk about evaluating the contract, and this applies really to amendments as well, but evaluating the contract that you're offered by the MCO. The first negotiation usually you'll ever have with them is how long you get to actually review it before you have to sign it. It's a good test of the MCO's flexibility, actually, in my view. The first time you can try out some of the negotiating tactics because I'm going to give you in this process to see how flexible they are. So here, you definitely want to have enough time to review the contract. Many of you probably have procurement policies, right? Before you buy goods or services from vendors, you probably have to jump through some hoops, right? Because your organization wants to make sure that you get the bang for your buck, that you are making wise procurement decisions. So you might have to go to multiple sources in some cases, get different bids, and then decide, maybe there's a group that decides whether you should proceed, maybe sign off by different levels of management. That's when you're buying goods or services. Well, shouldn't you have a robust process as well when you are selling services to a payer? I would tend to think so, because you want to make sure the revenue stream is adequate to cover your cost of service, cost of care. So you may have to say to the plan, we need at least 2 weeks to do this, to run it through our system to make sure that we're getting enough, to vet the contract. You may have a lawyer you want to share it with, you may share it with a financial consultant, if there's a value-based payment methodology. The first thing to negotiate is the adequate period of time to review the contract. If it's too short, you won't be able to do it. And some providers I know are hesitant to ask for more time. When they hear from the MCO, we need the contract back in a week, they hesitate to say, no, we need 2 weeks. Well, I would urge you to reconsider that hesitancy. No provider, in my view, has ever looked bad by telling an MCO, I need more time to review the contract. You only look good, in my view, right? Because the larger institutions and organizations, of course they vet their contract. It's not going to be signed overnight. So why too, even if you're a smaller guy, why shouldn't you too also insist upon the same rights to review the contract? Because it tells the MCO, they have a robust process too. So I think you look good by asking for an adequate period of time to review the contract. And certainly if you hear that the plan only has a day or something, or 2 days, or some deadline that they have, well, you want to vet out whether that's the case. Does the plan really have a deadline to submit something to the state? Or do they just make up an arbitrary deadline from a project management perspective to get it done? That makes a difference. So ask for adequate time. Step 2, make sure you have the right people in the room. Assemble a mini contracts review team. Whoever you think should be reviewing the contract. Many organizations include somebody from the billing side, somebody from the clinical side, from an operations side. You can define who that little mini team should be to review the contract that's being offered by the MCO, and then who the right point person is to negotiate. It doesn't have to be the CEO. I just saw a very effective negotiation be completed in a different region, and their leads, their point people was the CFO and their billing person. And those two people consistently were on calls with every MCO that they negotiated an agreement with. Was there a larger team behind the scenes, behind the curtain? Absolutely, that's within the organization. But those were their 2 points of contact for negotiating the contract with the MCOs. You can also use this team to spread the work. So I had a CFO that basically created his own checklist for reviewing contracts, and he was on the team. So he was responsible for the financial terms that typically were at the end of the document for reviewing them. So he had a specific portion of the contract that he was responsible for. There's no rule that says you can't divvy it up. Only your lawyer has to read it through cover to cover. You can divide it up at the organization so that pieces of the contract are being reviewed by each team member to make it more accountable. 3, assemble the documents that you need in order to do a good contract review. I already mentioned the model contract, how important that is. But what about the contract itself? I was having a battle here in Washington State because I think it was United. United was not turning over the regulatory appendix, which I knew applied to their contract. They were saying, no, we have they had the model contract appendix, basically, the provisions required by the model contract. But United is notorious for having multiple appendices, and they didn't include the state mandated clauses. These are clauses in state law that basically overrode their contract, and they were insisting that it didn't apply. And I knew that other providers had this appendix, and they were just not turning it over to this provider. So the provider had to go back and forth with United several weeks until they got it, because somehow the provider rep on the United side didn't realize that appendix was applicable to the contract. And it was a huge deal, because your state law, just like the model clauses, basically supersede clauses in the base agreement. And United, which has the most one-sided contract in the business, that was very important, because their provisions, you want them superseded by state law, because that inserts protections for you in the agreement. I've also seen contracts where plans just leave out exhibits. They'll refer to exhibits A, B, and C, and you look at the contract and they'll have A and B. And I don't think they're trying to cheat you of an exhibit. I think it's sort of like the contract reps are compiling these contract documents together from multiple types of contract templates they have, different exhibits, kind of like a menu. They're going down the line to create the contract, and they leave things out accidentally. So they need to have the exhibit, or they just don't include it. United always leaves out their payment exhibits. I mean, I don't know why, but it's very hard to get from United their payment for how much you actually get paid. So you have to go back and usually ask for that. Sometimes the MCOs just don't know your scope of services. One of the most important checks is to make sure that everything that you provide, there's a payment rate associated with it. Because if you don't get usually a kind of scope, sometimes have a reimbursement exhibit that includes compensation for all your services, the plan could be leaving that out. And it's not because they're trying to cheat you. Many of the provider reps just don't know what your scope is. Behavioral health services, there's a long list of different types of services you can render as a behavioral health provider. How do they know what you do? They don't know you. They don't know you from Adam. They just don't know what your scope is. So always want to review the contract exhibit to make sure it covers your entire scope of services. What about past operational performance of the plan? Would you believe it? Some plans are better than others. Some have a better reputation for paying claims, utilization management, and review decisions. How does that factor in to you? Well, you can decide. Based on this plan's reputation or their performance, because we've been in their network, do they pay me on time? Or are they responsible for a lot of denial? And how do they deal with utilization review? Are they responsive to my request? They may be required to contract with you, but you may not be required. You probably are not required to contract with them. Let me repeat that. I think people lose sight of that. The MCOs are required to contract with you if you're an essential behavioral health provider. It does not mean that you have to contract with all the plans. That's their contractual obligation, not yours. I've had providers who decide that they're not going to contract with all the Medicaid MCOs in their area because they have concerns about the operational performance of some. In one state, a new MCO came into the market, and the provider said, and FQHC in this case said, I'm not going to contract with that new MCO. And I have serious concerns about whether they can actually get their systems and team up running. So they did not contract. They told all their patients, we are contracted with this one and this one and this one, but not this one. So if you want to continue coming to us as a number of providers, you have to be involved in one of these three plans because they have significant concerns. That's fine. You are allowed to consider that. Now, I'm not saying that's the only remedy, but let's say you have a plan that denies a significant percentage of your claims. That might influence what you want to negotiate for payment, because you may now know going into it, you know what, we only get paid for 75% of our claims. That means for us, we need to negotiate a higher reimbursement rate because we know we're not going to be paid whole on those claims that are submitted. What about the MCO's financial stability? Some of these MCOs do go out of business. They lose millions of dollars. You may have heard that in, I think it was Nebraska or Idaho, one of those states. I think it was maybe Nebraska. United Healthcare pulled out of the Medicaid market. Iowa, Iowa, they pulled out. They were losing $200 or $300 million a year. So they exited the marketplace. I've had other plans exit and bail on a market because they were losing too much money. Well, your relationships with a plan that goes out of business, that can impact your financial stability, right? How much money are you going to get paid by a plan that's in bankruptcy? Not very much. If you have a payment dispute with a plan, and they're not yet in bankruptcy, but you know that their financial condition is poor, you might be motivated to negotiate a settlement, even though it's not going to pay you in full, but it's going to pay you something more than you would get if they went into bankruptcy. So the plan's financial stability helps you get paid, basically. A plan that is not financially stable, you are taking more financial risk. One of the first plan in the DC Medicaid market that stopped paying providers during federal sequestration of dollars was a new entry in the market, that new plan, because they met their minimum reserve requirements and they didn't have deep pockets. And then they stopped paying providers. So actually that provider, that FQHC that didn't contract with them, they were actually helped twice. They were also helped by the fact that they did not take any financial risk and lose any money during sequestration, because they were not contracted as a provider with that particular health. This is usually where somebody asks me, how do I get access to the plan's financial data? Is that your question? So the way you can access it is through, of course, the plans are required to file. And you can access it through the National Association of Insurance Commissioners website, NAIC. Plans have to submit quarterly, in some cases monthly, financial reports. They used to be free. I think there's now a nominal fee. But you can basically look up the plans that you contract with and see what their bottom line is. You can have your CFO look at it and actually tell you what some of those numbers mean, because it confuses me. And figure out, does that plan have additional loan or note from a bank because it's not doing well financially? Is it on shaky terms? And that might lend you to make certain decisions about whether you contract with them, how you contract with them, or how you resolve any disputes. Does that answer your question? Or you got more?
It does. The State Office of the Insurance Commissioner, the Washington State OIC, collects information for carriers in the state of Washington. It's something that I looked at in the past as well. These are very informative and very detailed. Washington State has a very highly regulated insurance market, so they do a great job of keeping this information. It's accessible from their website if you know where to go.
And then you actually have to look at the contract. You have to review the terms of the contract and see whether the terms are actually going to help support what you do. If you review the terms and you feel like you're taking a ridiculous, unsupportable amount of financial risk, where it's going to destabilize your organization, not perpetuate and further your mission, then you might come to the conclusion at the end of the day that it's not a contract that you want to be part of. So in my view, I'll go through the specific provisions in a moment, but you should know what the provisions mean in the contract. And you should know how they impact your organization from a financial, clinical, and operational perspective. You should understand what your obligations are and what their obligations are. I know that initially some of these contracts look like they're written in another language, and my view is that you need to unwrite them from that language and put them into something that you can understand. Because in my view, the number of disputes can be minimized by having clear contract language with the MCO. Because ideally, you don't want to have to bring lawyers in to resolve disputes. You want to be able to resolve disputes on your own. And one thing that can allow you to do so is having terms that are clear and specific and not subject to confusion or ambiguity. Make sure it includes all the related and relevant exhibits and appendices. Make sure you review the plans, the manual. We'll talk more about utilization management and review later. But usually, most of the utilization and management policies of the plan are in the provider manual that they have. It's not typically in the contract itself. References to statutes, codes, and so on and so forth. If there's a regulatory citation and you have an obligation as a result of it, you probably should know what that citation is. One of the plans here in Washington State, they had a mistake in one of the citations. They referred to a citation incorrectly and they hadn't caught it. The provider had to go back and say, hey, that's wrong. It needs to be this. And the plan acquiesced. And some plans are good about that. One of the other plans is not so good about that. Every year I find when I review their contract multiple times a year that they leave out the word not in a very important sentence. And I tell them, I point it out. And then I see that contract again, reusing the template with the word still missing. So some of the plans update their contracts, some of them don't do that very well. At the end of the day, you'll have to make a decision, a business call, whether you have a good contract or a bad contract from a financial, legal, and operational performance. And that's just a business decision. That's not a legal one. All right, this is a good place to break. The food is ready for lunch. And we'll break until 1 o'clock. And when we come back, we'll talk about all the terms that are in the contract.
Too far from you?
Yes. I'm stuck to you something that is interesting. I'm like, oh, that's good. I want to look into that. Yeah. I'll tell you guys what it is. Okay, now that it's clear over my head. I know.
Give you my business card.
I'll share that. No. Well, I'm in accounting next to them.
Okay.
And we have some of our contracts and